Hello, good evening, everyone. Welcome to my Vivences and the European Fertility Society. We are back once again, and I'm really happy to have you here. Dr. Elena Santiago is with us. You already can see her. Hi, Dr. Elena. How are you?
Hi,
Hope you are
hello,
having
I'm very
a
good,
good
thank
day.
you.
Thank you so much for
Yes, as well.
joining. It's been a
Thanks a
busy
lot
day.
for invitation.
It's been a busy day, I'm sure.
Yeah, like always, but it's fine.
Glad to hear that, of
Very
course.
glad to be here.
And I'm happy to have you here for sure. So today, as always, just let me remind everyone that we will start with the presentation on our topic, but afterwards there will be time for your questions. So as always, please put those in the chat, and Dr. Elena Santiago will be happy to answer them for you. And remember, it's all anonymous, so I can only encourage you to type in anything that's on your mind. And of course, today, as you know, we will talk about IVF add-ons. And there are some very interesting add-ons that we will discuss. I'm sure that you are definitely wondering about PRP, endometrial PRP, but also ovarian PRP. But we will also discuss DNA fragmentation option, and as well as some male factor tests that may be useful for you. So first we will start with the presentation on those topics, but afterwards, as I mentioned, we will definitely have a Q&A, so don't hesitate and ask as many questions as you'd like. We have about 30 minutes for those, so I think it's enough, pretty enough for your questions to be answered and thoroughly, as always. And remember, it's also being recorded. And before we start with our presentation, let me just remind you that Dr. Elena Santiago is the fertility specialist and gynecologist at Vida Fertility in Madrid. And I've heard that today is not as hot as it used to be. So I'm happy that you are enjoying some cooler time, let's say. And I think that it's we can begin with our presentation. And are you ready?
Yeah, sure.
Brilliant. Thank you so much. Then let's go with the presentation. And as I mentioned, you can type the questions now or later on in the chat. Thanks a lot.
Thank you, Caroline, and thank you everyone for being there today. We're going to talk about IVF add-ons, as Caroline introduced already. This is making informed choices for your individual needs during an IVF procedure. So we have different options, but obviously we need to decide which are the best for each patient. First of all, I wanted to introduce you a little bit more our clinic. As you already know, we are in Madrid, but we also have another center in Alicante, where we are all experienced specialists trained in cutting-edge technologies and committed innovation. We gave tailored treatment plans. We have a very dedicated doctor and coordinator for each patient, individually and personalized. And we give expertise in remote treatment management because we are very used to it. So obviously we have a multilingual support to ensure clear communication with every patient. We also offer all the possibilities in terms of treatments right now, as also the law here in Spain does permit this kind of treatments as well. As you know, it depends on the country. So here the law is quite open-minded, and therefore we can give all types of treatments, or nearly all the types of treatments that we can look nowadays. So what are these possibilities of add-ons in an IVF treatment? As you know, IVF in reality is a treatment where we have different stages, and in those different stages we can add several techniques depending on what we advise each patient, or sometimes what they want to add on as well. Okay. So I will now explain you little by little every add-on, but well, just to show you that we could have add-ons during ovarian stimulation, sperm selection, as Caroline already has said, Then we go for the egg retrieval and fertilization of the eggs. Then we see how the embryo development is going on at the lab, where we can see different add-ons as well. And in the end, we'll see the endometrial PRP treatment that could be done before doing the embryo transfer. So I'm going to start with the ovarian PRP treatment that can be done before we do normally an ovarian stimulation. This is a technique that is used to activate the follicles that are silent. So when we normally do an ultrasound to check the antral follicles in our ovaries, and therefore know how our ovarian reserve is, it's true that there can be other follicles present in the ovaries that we normally don't see because they are smaller in earlier forms. So therefore, these follicles normally are not sensible to the gonadotropins that we are going to administer for that ovarian stimulation. They don't have those receptors needed, but if we give PRP treatment, maybe these smaller forms of follicles could be activated to later forms where they can be gonadotropin dependent and therefore grow with the stimulation. So that's what we are looking for with this treatment. Obviously, this is advised to be done in women with a low ovarian reserve. We say that is normally useful when AMH levels are going to be lower than 0.5 nanogram per milliliter, or when the antral follicle count is lower than 2 or 3 follicles altogether in both ovaries. And also, it's recommended to be done in women aged lower than 45 years old. It could also be a technique that to be considered in younger women, under 35 years old, with premature ovarian failure, even not having already cycles, and this menopause situation already, but quite young. So we could try and see if this PRP treatment could allow us to have a response later to the gonadotropin treatment or the ovarian stimulation. The technique, how do we do it? It's quite easy. We only need a blood extraction to be done like 1 or 2 hours before the procedure. We do the preparation at the lab, which is quite easy. We just take the growth factors that are inside the plasma, concretely inside the platelets. And once we have everything ready, we do the procedure, which is exactly the same as when we are doing the egg retrieval, meaning that vaginally with an ultrasound, we are going to do an infusion of the plasma directly in each ovary. It's very short procedure, but normally the patient is going to be under sedation. After this, we normally wait for 1 or maximum 2 cycles to start the ovarian stimulation. Now I wanted to talk about sperm selection techniques that can be used before fertilization. These techniques depend a lot in what we've seen before, obviously, in the sperm counts that we have from the patient. And also with those sperm counts, we need to see, depending on the history of those patients, if they need to do other diagnoses, such as, for example, if they had several miscarriages or implantation failure. We normally recommend to do what we call a DNA fragmentation test. And this test, it's better if we see single and double strand DNA fragmentation. If, for example, this DNA fragmentation the result comes back to be abnormal, meaning very high percentage of the sperm with that DNA fragmentation, then we can use specific selection techniques, such as, for example, the 𝐸𝐵𝐺 or the fertile chip, which is a mechanical way of selecting the sperm before we go ahead with the ICSI, meaning that from the general sample, we only get the sperm that doesn't have that DNA strain fragmentation. And therefore, this could improve our results in terms of fertilization rates, embryo development, and obviously, finally, the results of, pregnancy rates. There are other techniques also used. Normally the 𝐸𝐵𝐺 is used in double-strand DNA fragmentation, but there are other techniques more to do when we have higher single-strand DNA fragmentation, such as, for example, the sperm law, the MAX, or the PICSI. These techniques are more like chemical or biochemical, meaning that they select the sperm depending on concrete molecules. The 𝐸𝐵𝐺 we've said that it's more mechanical, and there are other techniques too that we can use. For example, when we see important teratospermia, meaning loads of disorders of the morphology of the sperm. If this is very high and we have only a few sperm that look normal morphologically, we can select them with a special microscope, which is called the IMSI, where we have a higher magnification of the sample, and therefore we can see better each sperm, so that we can decide which we can use before doing the fertilization. After the fertilization takes place, then we need to see the embryo development in the lab. And as you know, we need to use incubators for that, so that we have the proper environment for the embryos to grow, meaning same temperature, gases, as if they were inside the fallopian tube or the uterus of the mother. Nowadays, here we have several options which are available in many of the clinics where you can do the treatments. Obviously, it depends, and you can ask for them, but they are quite known worldwide right now. And we have different options of incubators where obviously we have these conditions needed for the growth of the embryos, but also normally they can have a camera inside for each patient individually, so that we can see the embryo development of each patient at all times, having a video so that we can check how the embryos divide themselves from the beginning, meaning that these divisions are correct. So we get, from one cell, this cell divides in 2 cells. If, for example, we have one cell that divides itself in 3 cells, that's not a good sign, and more to do in the first divisions of those embryos. So this is something that can give us much more information. Not only we are going to see the quality or morphology of those embryos, but also the kinetic divisions that they have gone through until we get the proper embryo at the end of the culture. So I do recommend always to use this type of incubators for all patients, because there are no disadvantages, but obviously sometimes it can make the treatment to be more expensive, and therefore it's not something mandatory or that we have to use yes or yes. It depends on the case, but obviously it can help us a lot to see or have more information about the embryos. And also we've seen in our clinic, at least, we use the first one, the 𝐬𝐮𝐬𝐜, And we've seen, comparing to the traditional incubators, that we normally can achieve more blastocysts of good quality in overall, no, in general, with the time-lapse incubators. Sorry. Then this is a very nice and easy add-on, which I believe it's done already after several years, at least 10 to 12 years. We've been doing already the culture of the embryos until the blastocyst stage. It seems easy, but obviously it depends on the lab, it depends on the conditions. Sometimes when we are doing treatments in public hospitals, they still do embryo transfers in day 2, day 3, where we say it's the cleavage stage. But in the majority of private clinics, and at least here in Spain, I think that the majority, we work already with the blastocyst stage at all times. Mean that also with patients where maybe we can have only one egg, we prefer to see that the development of the embryo until the end, see if that embryo can get to the blastocyst stage, and therefore give more probabilities of pregnancy when doing the transfer of a good quality embryo, rather than rushing out and doing the transfer in a day 2 of a 4-cell embryo. Okay, so we do avoid transfers of embryos that maybe are going to stop their development either at the lab or either inside the mother's womb. So better embryo selection always. And it allows one important thing as well, which is doing a single embryo transfer in the majority of the cycles, with very, very similar results to a double embryo transfer. And this is very recommended in the majority of the cases. If we do have very good quality embryos, we do prefer to transfer one embryo at each time, so that we reduce the possibilities of having multiple pregnancies. We are never able to avoid having a multiple pregnancy. You have to take this into account, because even one embryo could divide by itself and provoke a multiple pregnancy. And that situation is when we have identical twins. This is only 1% rate of the cases, but obviously it could happen. If we transfer 2 blastocysts of very good quality, obviously it depends, or the pregnancy rates are going to depend on many other factors, such as the age of the patient. But if we are having maximum success rates with only one embryo, why do we have to put 2, where I can risk a lot having a multiple pregnancy, where, as you know, afterwards, even for the mother and the babies, we can have more risks during pregnancy. I'm talking about gestational diabetes, preeclampsia, hypertension, premature delivery. So we prefer, as gynecologists, to do things as simple as possible, and reduce the risks as much as we can. So we do prefer each time having single pregnancies rather than double pregnancies, or even sometimes having a pregnancy of 3, because if you put 2 embryos and one of them divides by itself, we've seen that you can have a triple pregnancy, and this is very, very risky. So we don't want that, and we try to avoid it. Then I wanted to go through PGT-A testing that probably you'll know about already, which is something that we do nowadays quite a lot. It's normally done in a blastocyst stage, which we were talking about, and we have different types of PGT-A testing. The most common one is the one that we say it's called the PGT-A, where we can see the chromosomes of each embryo by doing a small biopsy of the trophoectoderm, which are the cells that surround the inner cell mass, which will be the proper embryo. So we are taking part of the future placenta, let's say, and with more than 90% reliability, we are going to know if this embryo is chromosomically healthy or not before we do the implantation of it or the transfer. This is very commonly used nowadays, for example, in all patients that are older than 38 years old, but also, well, when we have several miscarriages, implantation failures, it's also recommended. There are other types of PGT-A testing, more specifically, which are called, first of all, the PGT-M, which is the screening for single gene known disorders, such as, for example, if we know that both parents carry the same mutation for the cystic fibrosis, they will have a 25% rate or chances of having a baby with the disease. So as it's a quite severe disease, we can check the embryos for the mutation before doing the transfer. In the same way, if we already are going to do a PGT-M test, we could do PGT-A at the same time. So we check either for the mutation and the chromosomes all together so that we decide which embryo has the best possibilities to be healthy and have a healthy pregnancy, obviously. In the end, there's another type of PGT testing, which is called SR, which screens for chromosome rearrangements, like, for example, translocations and inversions. This is when maybe we have normally a healthy patient, but we've checked their karyotype before going ahead with an IVF treatment, and we see that they have a disorder named translocation, meaning that they have a small piece of a chromosome stuck to another chromosome, okay? This, for the patient, normally doesn't mean that they are going to have any problem or disease, but unfortunately, it will change normally a lot the pregnancy rates and the chances of having healthy embryos. So these people, for example, at home, if they get pregnant, they could have a healthy baby. And then in the majority of the cases, it's going to be difficult to achieve that pregnancy. Or sometimes they have many miscarriages before they come to the clinic. So we check the karyotype, we see the disorder, and then we are able to do an IVF treatment with this PGT-SR so that we only transfer the healthy embryos. And now, well, after talking about all the embryos and everything, I wanted to also see another add-on, which is obviously the endometrial PRP treatment. The preparation of the PRP is exactly the same for the ovarian infusion that we've talked about. So we get again a blood sample like a couple of hours before. We are going to do the uterine instillation or infusion. It's a very, very easy technique. It takes us like just a few minutes. And we normally do 3 infusions before embryo transfer. But the only thing is that we need to be with the patient 3 times before the embryo transfer, meaning doing those 3 infusions normally at least 2 or 3 days before the transfer, and the other 2 separated by 2 days or 3 altogether. So maybe the patient needs to be like 1 week, doing these 3 infusions, and then 2 or 3 days later they will do the proper transfer. This is indicated for women that have a thin endometrium, meaning that we always get maximum that we don't get that endometrium of at least 7 millimeters that we want for the embryo transfer. Also, when we have several implantation failures and we don't know the reason, we can use this technique to improve those pregnancy rates. And also in patients where we know that they have an Asherman syndrome, this is when we have like adherences of the tissue inside the uterus, no, of the proper endometrium. This type of PRP does increase pregnancy rates as well, and avoid having other problems with the tissue before the embryo transfer. So it aims to improve endometrial receptivity, increase the thickness, and enhance, obviously, the pregnancy rates. And I wanted to also do a quick mention of all the artificial intelligence tools that we have nowadays, which are other add-ons that we can see. There are many options. Obviously, not always all the clinics have all the options all together. They decide maybe which is the best options for them, and they do offer to each patient if they want to use these artificial intelligence tools. Other times there are tools that we use for ourselves, no, in the lab, or maybe the tool also could help us decide medication to use for the ovarian stimulation, or for the follicular monitoring as well with the ultrasounds. At our clinic, for example, when we do oocyte preservation or vitrification, we have a tool where we can see with the photographs of each egg that we achieved after the egg retrieval, and depending on the characteristics of each patient, they can give us the pregnancy outcome prediction with that cohort of eggs achieved. So therefore, this helps the patient decide whether they feel fine to not to any other treatments, or maybe they decide to go ahead with more stimulations so that they can accumulate more eggs. So it helps make decisions. And there are many of these tools used nowadays for the embryo development, as well as with the time-lapse incubators that we've seen already. It helps you to choose the best embryos regarding different algorithms that compare, no, the kinetic of each embryo, the morphology of each embryo, and it gives you a solution for the embryologist as well, or a tool to help them decide which is the best embryo. So what are the taking-home messages today? So we've seen that there are many add-ons available in artificial reproduction techniques. Not everything needs to be applied to every case, that's true. Some may help to achieve better outcomes in every case, as for example, the time-lapse incubators, blastocyst stage, artificial intelligence tools, but others will depend as well on the specific characteristics of each patient. As for example, no, as we've seen, PRP, ovarian PRP, endometrial PRP, they have their particular indications depending on the case, sperm selection techniques as well, PGTA testing or PGTM, PGTSR as well. So the importance is to always provide the appropriate guidance for each case. So individualizing each case is always the key. And that's why, well, we need a gynecologist or an expertise in the clinic to recommend what would be useful in each case. So that was all for today. Thank you so much for your attention. And I'm here for any questions that you can have right now.
Brilliant, as always. Thank you so much for walking us through all available options. I think that there are even more than those, but it was really interesting and of course informing about the options that you have, that you offer at the clinic, Vida Clinic, of course. So thanks a lot for this. And now we will move on to your questions. So go ahead, type those in. I'm sure you have more. There is one question here, but before we do, I do have some questions for you. And in the meantime, please remember that you can ask anything that's on your mind. And I'm sure Dr. Elena Santiago will be happy to answer them for you. Okay, I don't want to keep you waiting. There are questions in the chat, as you can see, Dr. Santiago. So let's have a look, okay? Let me start with the first question that we've received. Interesting question for sure. We were looking for a clinic in Spain where to do our IVF cycle with PGTM. You mentioned that during your presentation as well, right? So we have been told we need to go for genetic commission first in Spain. Can you explain how this works? We don't have one of the common disease gene risk. I guess that's why we would need the genetic commission. Anything you can advise here?
Yeah. So PGTM is not allowed for every genetical disease that we know. It needs to be normally known genetical disease, common, as you correctly say, but also severe, meaning that afterwards, the life of that baby or that child could be really affected or really in risk. So not all the diseases can be diagnosed. If that's the case, it's true that you need to go through this national commission, and unfortunately it takes time. Normally we need to wait for the case to be solved from 6 to 12 months.
Okay.
And not all the cases obviously are going to be accepted.
Okay.
All right.
So that's quite a long time to wait as well. So it's really important to keep that in mind.
Unfortunately, yes. Yeah.
All right. Thank you so much. I think that this is an important message here. Yeah, that you need to wait until even 12 months. So thank you a lot for that. If there's anything else you wish to ask, you know what to do. Let's have a look at the next question that we've got. If you have women falling within all criteria other than age for ovarian PRGF, is there any exceptions? I have just turned 46. I have had a number of egg retrievals and always get around 4-6 follicles. Anything you can help with this one?
So it's true that you do have a quite good response in number of follicles with because of your age is a very good response. The problem with the PRP treatment is that it doesn't increase the quality of the eggs. We are only able to at least increase a little bit the response, not a lot. So I'm talking about 1 or 2 more follicles in that ovarian stimulation that we do after the PRP infusion. And therefore, I don't think that in your case in particular, it's going to help a lot. That's why we put this limitation of age in 45 years old. Obviously, if you've just turned 46, we can always use it, but I'm not sure that it's really going to help in your case, because in the majority of women over 45, the quality of the eggs, even if the ovarian reserve is good, the quality is going to be very, very low, and therefore the pregnancy rates are really, really low.
Okay, thank you for that. Yet another advice here. And let me just have a look. Of course, more questions are coming in, I'm sure. So thanks for those. And can you also perform sperm selection technique with easy material? Thanks for the interesting presentation.
So this is a very good question. Unfortunately, we are not able to use this type of techniques with the biopsy. This is because of the quantity of the sperm that we collect within a biopsy is not enough to go through these chemical or filtration techniques that we were talking about.
Okay. All right. Thank you for the clarification. And let me have a look. More questions are in. Sorry, just give me a second. Yeah, there's the next question. Which of these strategies you showed today would you use when you can retrieve a good number of oocytes, get all fertilized, but a very small number then grows to a blastocyst?
So, for example, in these cases, you have to suspect that maybe we could have a high DNA fragmentation, because this is one of these scenarios where maybe it's because of the egg, but we never know. We can't test the egg, but we are able to test the sperm. So let's see if maybe we do have a high DNA fragmentation. Then we can use these extra selection techniques of the sperm before the ICSI and see if we can improve embryo development and get more blastocysts. And also time-lapse incubator is going to help you maybe achieve more embryos, as we are not needing to take outside embryos of the incubator at all times to see them under the microscope, and therefore these environmental conditions are going to be much more stable, and we do see maybe more blastocysts growing in some of the patients.
Okay, thank you so much. I think that, if I may ask, so is there like an extra cost for that embryo?
Yes.
Sorry, time lapse. Is there an
Normally, yes, it's
Okay.
an extra cost. Yeah.
Okay, but I
And
guess
it's not very expensive. Huh? It's
It's worth it.
affordable in the majority of the cases. Yeah.
And in your opinion, it's definitely worth it, I guess, right?
It's worth it because, as I said, it doesn't mean any disadvantage at all. So it's only advantages, having more information,
Yeah.
better environmental conditions. So why not use it, no?
So I guess most of the patients still actually go for it, like they accept that and they want to have that included, I guess, right?
Yeah, that's
The
it.
majority
And
of patients.
even tell you that when we do PGT-A testing, which is very, very common as well nowadays, as I said, it's better for the embryologists also to see for each embryo when is the best time to do the biopsy, because it's not
Okay.
always
Yeah.
the blastocyst in day 5 is perfect for that biopsy. We need to wait, a particular expansion. Maybe we need to wait even for day 6 to do this biopsy, or maybe in day 5 during the afternoon. So it gives us more information as well in terms of that, deciding when is the best time for each embryo to be biopsied.
All right. Okay. Thank you so much again for that. Next one, you also mentioned that. So what can you say about AI tool? Can it give a glimpse in terms of the embryo's chromosomal abnormalities?
This is a very good question as well. It's
Yeah.
true that obviously all the studies that are going through right now with these new techniques, they try to see, if the morphology, the divisions of the embryos, and many other tools that we can use nowadays, metabolism of the embryos, has to do with chromosomical disorders. We need a little bit more time to see if this is like this, but I believe that in the future, obviously, we can get rid of the biopsy and have other tools to see healthy embryos.
Right. Okay. And do you also perform non-invasive PGT-A, which is something that is still experimental, I think, but have you been able to try it already at the clinic?
So not until now, no. We haven't done it. So we've seen several discussions about it and everything, but it's true that still is a little bit experimental. We also believe that when you have a good team doing those biopsies of the embryos in terms of not harming the embryo, they are used to doing it, and we don't get bad results in terms of by doing PGT-A testing, we are going to harm embryos or decrease pregnancy rates. So, well, nowadays we do have better results with PGT-A testing, and that's why we go through this.
Makes sense. As I mentioned, this is still, I think that it's still experimental. So I think it's, something that we need to wait for a little bit longer again to prove that it's actually working and it gives the results, right? We need.
Yeah, it's true that it gives you a lot of information, and it's very good, and probably in the future it's going to be there's going to be more viability with maybe not the non-invasive techniques, but nowadays it's true that we do have better results with the PGT testing still, and you can decide better which is the best embryos. So
Definitely makes sense. Yeah. Thank you so much for that. And let's have a look. Now we will go for a longer question. And I do see like 2 questions. So if you have more, go ahead, type those in, okay? And in the meantime, let's have a look at this longer question. We had a fresh IVF cycle last November with donor eggs. 13 eggs were retrieved from the donor, all fertilized, 11 embryos initially, but we were left with only 3 blastoses by day 6. My partner was 38, non-smoker with high DNA fragmentation, but normal karyotype. We used 𝐬𝐮𝐬𝐜𝐫𝐢, PICSI, and EmbryoScope for that cycle. What could have caused the low blastulation rate? What could be done to achieve better results? And what vitamins can be prescribed to improve sperm quality?
Okay, so there are many questions here. First of all, it's true that fertilization rate was quite good. And afterwards, the number of embryos was maybe a little bit lower than expected. We say that in average, we normally can get around 50% blastocysts of the initial number of fertilized eggs. Okay, but I also tell you, with ectonation treatments, it's not only important to see how many good quality embryos we achieve, because each embryo already has going to have a very good quality. So therefore, pregnancy rates should be quite high with each embryo, and sometimes we don't need so many. So let's try with those embryos, see if you can achieve finally the pregnancy, and don't worry so much about the number. This is biology. We talk about average, but each cycle can be different. Sometimes with 6 eggs from a donor, you achieve 6 blastocysts, and sometimes maybe you don't achieve blastocysts at all with 12 eggs. So this can happen. This is biology. Even with the same donor, you have different results, different cycles. It's not always everything have to do with the sperm. So if you've done a selection technique, ICSI, consider that you don't have such a bad result. 3 blastocysts seems to me a good result and very good options of pregnancy. Okay. Afterwards, you've asked about the sperm, what type of vitamins, no, that we can prescribe to improve. Okay. It depends on the type of fragmentation that it was high, but obviously if you've used 𝐬𝐮, I believe it was the double strain fragmentation, and therefore we need antioxidants such as, for example, zinc, Q10, DHA, well, those like omega-3 fats that we always talk about. And also it's very important to have some curcumin, which at least until nowadays we've seen that with this we low or try to lower a lot achieve to lower a lot the double DNA fragmentation. But it's also very, very important to follow up as well the good life habits, not only non-smoking or non-drinking, also maximum 1 coffee per day, not drinking Coke or any other refreshments that you know that always have some sugar there, and this is very unhealthy. and well, try to look after also the meals, no? Try to eat as healthy as possible. It doesn't mean lettuce at all times, but obviously lots of fruits, vegetables, and cooking at home normally is going to be
No fast
healthier
foods,
than
especially.
buying
Right.
fast foods. That's it. Exactly.
True. Thank you so much indeed. And I hope that helped. If there's anything else, you know what to do. Go ahead, type this in. I do see another question here. Sorry, just give me a second. Is there anything you can recommend or have seen to improve equality?
This is the key
My
question.
favorite. Yeah, true.
I wished I had some tool
We
or
all,
something
yeah.
to improve this. Obviously, we're trying to find about it, but it's really, really difficult. Um, the same for the sperm. Obviously, it does work in some kind of way. Well, having good life habits, taking antioxidants, vitamins in a controlled way, obviously, could improve a little bit at quality and also ovarian reserve sometimes. Also, patients where inflammation is very high for whatever reason, because of life habits, obviously, but also endometriosis or any other condition, reducing that inflammation, I believe it could also improve egg quality. But it's really, really difficult to say, take this or do this, and egg quality is going to be much better.
There's no like, yeah, it's true. It's nothing like we can say that definitely this works, right? And it will improve it for you.
Correct.
Yeah, this is the
Yeah,
problem, unfortunately.
that's it.
Thank you so much
Unfortunately.
indeed.
Yeah.
But there is one more question, possibly our final question. So if you have more questions, please go ahead, type those in, and let's have a look. Are you seeing good success rates with endometrial PRP? I have thin uterine lining and recurrent implantation failure. I did one PRP procedure after my last DNC. Best lining has been 6.7 millimeters. Wondering if repeated PRP is recommended before next frozen embryo transfer. Anything you can advise here?
So it does increase in overall implantation rates. Sometimes also, as we've said, it helps with that endometrial lining, not always, unfortunately, but it's true that it's going to regenerate a little bit more the tissue, maybe improve vascularization, and therefore improve the thickness of the endometrium, as well as those the receptivity. No. There are also patients that maybe if this doesn't work, I don't know if that's the case, because 6.7 millimeters seems to me quite a good thickness. It's just there nearly in 7 millimeters. But I did had patients with maximum of 4.5 millimeters that maybe did have better results after a subendometrial PRP treatment. So this means not only doing the infusion inside the uterus and even let's say the plasma, but introducing little by little with a very small needle under hysteroscopy the PRP injections throughout all the endometrium lining. This could help a little bit more, but I insist, I don't think that's the need for you, as you have more or less a good endometrium in the end.
That's good news, right?
Yeah, that's good news, obviously, if it can help. And I believe another PRP treatment is good for you. Yes, if you can afford it, and go for it, because as I said, it's a little bit more complicated, as you need to go several times for those infusions to be done. But obviously, there's the same as with the time-lapse incubators. There are no disadvantages here. It only can give you advantages at least. So try it, because I think it's good.
Okay. Sounds good, I think. And let us know, of course, if there's anything else. As I mentioned, it looks like that was our final question for today. But thanks a lot. It's been a great session, very interesting session indeed. Lots of questions. So thanks a lot for that. And if there's anything else, we still have a few minutes, but if not, of course, remember that you can get in touch directly with Vida Fertility Clinic in Madrid and also Alicante, and I'm sure they will be happy to help you, and I will be happy to forward any of your questions as well, so you can email those to me if there's anything else that's on your mind. And I guess we will be finishing for today. And so thanks a lot, everyone, for joining us today. And Dr. Santiago, as always, it's been interesting, it's been informative, and I'm sure it's been very, very useful. And you can see there are some thank yous right here as well. So any final words before we finish for today?
Just thanks again for having me here today. It's been a pleasure. The aim is to explain things, help everyone that needs these explanations, to understand a little bit more about their case, giving them several other options that maybe they didn't see before. And well, for me, it's always a pleasure, and I'm absolutely available if you have further questions.
Sounds great. Definitely. Thank you so much indeed. Thank you for this session. And as always, we will be back with some more events, and Dr. Santiago will be back as well, I'm sure. So I'm really looking forward to it already. And stay tuned. As you know, there will be some more events. And actually tomorrow we will also be here. We will talk about PGTA. So you can go to myivfences.com and see all of our upcoming events. Tomorrow we will talk about PGTA. It will be only a Q&A session, so we will focus only on your questions on PGTA. So I can only encourage you to simply sign up today. And we hope to see you here quite soon as well. Dr. Santiago, thank you so much. Lovely to have you.
Thanks a lot.
Have a lovely evening, everyone, and see you soon. Take care. Bye.
See you soon. Bye. Thank you.